Well, buongiorno, good morning to everyone. I'm so sorry I cannot give my talk in Italian, but I will try my best. First of all, I would to thank to the organizing committee for giving me this opportunity to show us what we are doing on the ovarian reactivation field. The last century was characterized by the population growth, but this one is meant to be for population aging. Indeed, it has been estimated that by 2030, around 24% of European population will be over 65 years old. This is especially relevant for women because most of the human organs and systems start to show the first clinical signs of aging around the 60s or 70 years old, but the ovary has a unique decline in the reproductive performance starting on the mid-30s. Age associates a decrease in oocyte number, but also in oocyte quality, with increased aneuploidy rates, but also increase on the prevalence of genetic abnormalities, miscarriage rates, and infertility. But age is not the only threat for the ovaries. As Dr. Porcu has explained, the worst ovarian scenario of young women with premature ovarian insufficiency. But I want to highlight that even when the ovary loses the ability to ovulate, remains, as you can see here, a remaining pool of primordial follicles that hopefully can be reactivated to growth. Indeed, the histological analysis of ovarian biopsies of POI patients show that at least 39% show a few or numerous of these primordial follicles. The proof of concept of the ovarian reactivation or the ovarian rescue was published by Kawamura in 2013. They achieved follicular rescue and live births after using an in vitro activation with AKT stimulating drugs and ovarian fragmentation techniques in POI women. This paper showed that these residual follicles are able to grow and be ovulated and create viable embryos when the an adequate ovarian niche is provided. Since the first description of the technique, this technique has been modified to a less invasive and more easily applicable technique by avoiding the incubation with drugs and only focus on the ovarian fragmentation. This ovarian mechanical fragmentation allows the polymerization of actin, which at the end induces the secretion of growth factors such as CCN or BIC that stimulate the follicles to growth. This new approach, as I mentioned, avoids the use of AKT stimulating drugs, reduces the number of required surgeries as can be performed only in one, do not require ovarian cryopreservation, so we also avoid the damage to follicles induced by cryopreservation protocols, looks for the best vascularized site, and also allows for spontaneous pregnancies. Different studies have reported an overall pregnancy rate ranging from 30% when first describing the in vitro activation and ovarian fragmentation technique by Kawamura in a well-characterized POI population to an eventual 60% by ovarian fragmentation that has been achieved by the Anderson's group in a group of women characterized only by low AMH levels. However, the first randomized clinical trial testing ovarian fragmentation has been published recently this year by my colleague Cesar Diaz, who works in IBI London, in a population of poor responder women according to Bologna criteria. So after checking that they met the criteria, patients were randomized to receive the ovarian fragmentation into one ovary or to the control group. And then we compare the ovarian reserve parameters as well as the IVF outcomes in these patients. First of all, we realized that the ovarian fragmentation or the OFA technique resulted in an inhibition of the HIPPO pathway conferred by an 18.8% reduction in phosphorylation of YAP, which is how we measure how the root is inhibited. When we compare the ovarian reserve parameters between the control and the treated women, we realized that ovarian fragmentation significantly increased the total antral follicular count compared to control, but also increased the antral follicular count in the ovary where we perform defragmentation when compared on how it was the ovary before the surgery. However, serum AMH or FSH levels were not modified. When we compared the IVF outcomes between controls and the surgery group, although we realized that defragmentation promotes follicular growth and antral follicles to appear, the reproductive outcomes were not significantly different between controls and the surgery group, with a pregnancy rate ranging from 20% to 13.3%, so it's not a big difference. So these randomized clinical trials show us that the ovarian fragmentation is probably not useful for poor responders. However, some of the patients that were included in the initial phase of the study, they were really POI women, and that's why they were not randomized. But they underwent the phase 2 of the study, where we performed the ovarian fragmentation in both ovaries. In this specific group of patients with POI, we realized that the mechanical cutting of the ovary resulted in a 27.7% disruption of the Hippo pathway, which is almost double than what we observe in the diminished ovarian reserve ones. Overall, pregnancy rate for POI was 17.5%, which is pretty high, but when we examine in detail the diagnosis of our patients, we realize that those with a true POI syndrome reach a 7.1% pregnancy rate. But those that are known as fluctuating FSH or intermittent POI women, they get 41.7% pregnancy rate, which is very high. So these results show that the ovarian fragmentation technique is going to be especially useful for these young women with an intermittent POI, which are these ones that are poor responders but are traveling through the ovarian failure. We felt that this follicular rescue mechanism can be also the underlying mechanism of several spontaneous pregnancies and fertility recovery reports in infertile patients due to chemoradiotherapy after receiving a bone marrow transplant. Indeed, the bone marrow-derived stem cells are a population of mononuclear cells which include hematopoietic but also mesenchymal stem cells, all together with other progenitor cells. Thanks to the advances of hematology and oncology, they can be produced and mobilized to collect from peripheral blood by pharmacological treatments, so we don't need anymore to make this very invasive procedure of iliac crest puncture. We are always going to have an autologous source, and we don't need cell culture techniques to reach a relevant clinical number of cells. To test our hypothesis, our first approach was to design 2 different animal models by using chemotherapy to mimic the diminished ovarian reserve and the POI phenotypes. So once we made the ovarian damage, we infused the animals with human bone marrow-derived stem cells that, compared to normally circulating cells, show that they were able to restore estrocyclicity and estradiol secretion, even in the POI animal model, promoting follicular development. And after ovarian stimulation, we collect more M2 oocytes, we produce more 2-cell embryos, and even more important, when we assess the long-term effects of this treatment, we realized that the stem cells were able to restore the long-term spontaneous fertility, even in the POI model, by increasing litter size. All these positive follicular effects are mediated through the regeneration of the ovarian niche, which is the environment where the follicles have to grow. As we observe, increased ovarian vascularization, increased proliferation, especially on the granulosa cells, and reduced apoptosis and atresia. But the mouse ovary is completely different to the human one. And that's why we designed a second animal model using human ovarian graft from poor responder women that were xenografted into immunodeficient mouse. Once the ovary, the human sample, was established, we inject the animals with the stem cells. And compared to controls, these cells show that they are able to engraft into the human ovarian tissue, especially close to vessels and even in contact with granulosa cells, where promote the development of human follicles, also restoring the ovarian niche. Based on that, we moved to the first pilot study to test what we call the autologous stem cell ovarian transplantation, or the ASCO technique, that was performed in 20 poor responder women diagnosed according to Bologna criteria. The technique consists in the mobilization of the stem cells with a five-day treatment with G-CSF. Then the cells were isolated from peripheral blood by apheresis and infused into one ovarian artery by intraovarian catheterism. Then we performed a 6-month follow-up and an IVF study. And our results show that 74% of our patients show a positive response to the stem cell treatment, measured as increase in AMH or antral follicular count. And this positive response was correlated with the presence in apheresis of 2 different proteins that are stem cell secreted factors: FGF2, which is related with folliculogenesis, and thrombospondin, a key regulator of ovarian angiogenesis. However, we do not detect a difference between the infused and the control ovary, and this can, as both increase antral follicular count, and this can be due specifically to these growth factors that are circulating. So maybe they are also able to reach the second ovary. When we perform the IVF part, comparing similar amount of attempts of our patients prior to ASCOT and after ASCOT, we obtain more follicles developed, almost double number of M2 oocytes, as well as embryos. However, the euploidy rate was pretty low because around 85% of our patients were over 40. And makes sense, because the ASCOT technique is promoting follicular development, but seems that do not modify embryo quality. So this euploidy rate is the one that corresponds to the age of our patients. However, 3 pregnancies were achieved after embryo transfer, plus 3 more spontaneous pregnancy in older patients with long-lasting infertility that were not able to reach any single pregnancy in their previous attempts, even when they were younger, giving an overall pregnancy rate of 33.3%. These results show us that we achieve long-term fertility restoration in our animal models, but also that several of these poor responder women have a spontaneous pregnancy more than 6 months after the ASCOT technique. So the question was, are we inducing any positive long-term effect? In order to answer this question, we analyzed plasma samples that were collected prior to the technique on the day of apheresis, which is when the highest concentration of circulating stem cells we can find, and 3 months after the ASCOT. These samples were analyzed by a S.I.F.E.S technique, which is similar to NGS, but at the protein level. And we observed a clear separation of the 3 conditions, meaning that, well, we were sure that the apheresis sample is going to be different, but we were surprised that 3 months after the technique, the plasma proteome was still different from how it was, with a 23.6% differentially expressed proteins 3 months after the ASCO technique. The individual analysis of all these proteins present in plasma showed that the ASCO technique was able to increase in plasma the concentration of some proteins that are known as being decreased with aging, while decreases the concentration of some others that increase as the person age. Again, we found the thrombospondin 1, this key regulator of angiogenesis. So, in order to summarize what we have learned from this first study, we realized that the bone marrow-derived stem cells, as adult stem cells, made a big part of their effects by what is known paracrine signaling or paracrine mechanism, which consists on secreting positive growth factors that stimulate the follicles and ovarian stromal cells to grow and proliferate. But seems that they are also able to reach by themselves the ovarian tissue to do these positive effects. But there's another question to answer. Is this going to be also useful for POI women? So in order to answer these questions, we start what we call the second ASCOT study, or the ASCOT in POI. It was a randomized controlled pilot study with 20 women diagnosed with POI according to ESSER criteria. In this case, we established a maximum age of 38 because it doesn't make sense to produce embryos if they are going to be aneuploid. So the patients were randomized to receive the ASCO technique on the same way as we did it for poor responders, meaning we mobilize the cells, we collect them, and we infuse them into one ovarian artery or to the mobilization arm, where we made this treatment to mobilize the cells, but the cells remained circulating to analyze if they were able to reach the ovaries by themselves. Then we performed a 6-month follow-up and IVF cycles when follicles were detected. To date, we have included 10 POI patients, 6 to the ASCOT arm and 4 to the mobilization. They are younger than the poor responders with pretty high FSH levels and at least a year of amenorrhea. However, the study has been stopped for a while due to the COVID pandemics, but now we have resumed the recruitment and hopefully we will end soon. But I'm going to present the preliminary results that we have observed. The first one is that we have detected antral follicles and follicular development waves in more than 60% of recruited patients in both arms. These follicular waves were mainly detected, as you can see here, 3 to 5 months after the ASCO technique, which makes sense with the rescue or the reactivation of primordial follicles, because this is the time that a primordial human follicles requires to reach the antral stage. We initiate ovarian stimulation cycles in both study arms, and we have recovered 12 M2 oocytes compared to 0 M2 oocytes in their previous attempts. We have generated 3 embryos, performed 2 embryo transfer, 1 by study arm, and for now we have 1 ongoing pregnancy which resulted in the live birth of a healthy child in the ASCOT arm. But there's also another effects that are important to highlight, and are the ones related with all the menopausal symptoms that our patients get previous to receiving the technique. Because, as you can see here, in both study arms, we have detected spontaneous menses recovery, and our patients also showed an improvement on all the vasomotor symptoms associated to POI, like the hot flashes or vaginal dryness. And now let's move to the last technique that has been proposed, PRP. PRP is also based on the paracrine signaling, as platelet-rich plasma contains a high concentration of platelets with more than 800 types of proteins, cytokines, and growth factors, has been used for many years in different fields of medicine, like sports medicine or orthopedics, and PRP induces positive effects like promoting angiogenesis, inflammation control, cell proliferation, or cell migration through the release of growth factors that are contained within the platelets. Like, for example, FGF, VEGF, which is a key molecule for vasculogenesis. Since this technique was first described by the Greek group led by Dr. Pantos in 2016, most of the literature using intravarian injection of PRP was only case reports or small cohort series. But it was in 2020 when the big studies became published. And I want to focus first on the results of intravarian injection of PRP in POI women. To date, the biggest cohort has been published by the Turkish group led by Kakigloru, involving more than 300 women diagnosed with POI. After PRP injection, they detect an increase in antral follicular count in these patients and anti-Mullerian hormone levels. However, it seems that PRP is not affecting FSH levels. From these patients, 23 have a spontaneous pregnancy, and overall the technique gives us a 11.5% pregnancy rate that the authors expect to be even higher, because at the time of publication, there was 25 additional patients with cryopreserved embryos waiting for transfer. So hopefully this percentage is going to be higher. Similar results in POI have been published by the Pantos group in 30 POI women. In this case, all the pregnancies that they reported were spontaneous, which is like the best result that we can obtain with a ovarian reactivation technique, giving us an overall pregnancy rate of 11% more or less for POI women. But let's see how it works in poor responders. In this case, results are a bit different among the studies. To date, this is from the Greek group also. They showed the best pregnancy rate after PRP injection in a population of 30 poor responder women following the Bologna criteria, 46.6%, which is very high. It's like the higher one. For example, this study published in 2020, it was a non-randomized study, but they compared patients, poor responders, receiving PRP injection with control patients. They realized an improvement, that observed an improvement in ovarian reserve. They realized that the pregnancy rate increased when compared to control. However, no difference was detected on the live birth rate comparing to controls. And the biggest study that has been published recently this year by the same Turkish group involves more than 500 patients diagnosed with poor response, but in this case, they used the Poseidon criteria. They showed that PRP resulted in an improvement of ovarian reserve parameter, increased central follicular count, AMH, and reduced FSH levels. And on the IVF part, they observed, when comparing to previous attempt, more oocytes and blastocysts generated. Overall, the pregnancy rate for this study is 20.5%. It's important to have in mind some things when talking about all these reactivation techniques. The first one is that there's no going to be one universal technique for everyone, because as we have seen, the reactivation techniques show different effects and success rate in POR and POI women. So we should be carefully examining to what kind of patients are we offering each technique. This is especially important for POI because the POI spontaneous pregnancy rates, when we examine the literature, range from 2.2 to 14.2%. And that's a big difference. And this is especially due to this specific subgroup of fluctuating FSH or intermittent POI women that was described by Bachelot in 2016, that are these patients that during the first year after the diagnosis of POI, they spontaneously recover ovarian function because they have a better chance for getting pregnant. And we need randomized clinical trial with non-treated control groups, although it's very difficult because when we are talking about POI, it's not ethically acceptable to leave the patients by themselves to get pregnant. We need to offer them an option, and that's what makes difficult to have properly designed randomized clinical trials. But as highlighted in this paper published by Atkinson in Human Reproduction, further research is still required first to properly know how each technique is working on follicles and to what type of patients is going to be useful. Also to establish less invasive and more effective treatment, and maybe the answer is going to be on the combination of different techniques. Based on that, our group published last year a paper in the American Journal of Obstetrics and Gynecology where we were testing different plasma sources that were rich in stem cell secreted factor from the bone marrow or from the umbilical cord blood, which are also a very useful cells for the ovary, with PRP. We combine these stem cell secreted factors, we test them alone, but also in combination with PRP, as there are more growth factors within the platelets. And our results show that both in the short and long term, positive effects were observed with the stem cell secreted factor, especially when combined with the ones enclosed in platelets. But the best result, as you can see here, was obtained using the combination of the bone marrow-derived stem cell secreted factors with the ones enclosed in the platelets. So meaning a kind of combination of the stem cell secreted factors with PRP. But Our models are made with chemotherapy, so the damage is a bit different. And that's why we also test this specific plasma in an animal model of physiological aging. And it also works. So this helps us to validate also as an option, maybe for aged patients non-affected by POI or diminished ovarian reserve. We analyzed all the plasma sources that we were testing, and we realized that the one showing the highest percentage of upregulating proteins, some of them related with DNA damage repair, was this one that combines the stem cell secreted factor from the bone marrow with the platelet factors. And that's why we test this specific one again in ovarian cortex from poor responders xenografted into immunodeficient mouse. And we realized that this plasma provides specific proteins related to dormant follicle activation, DNA synthesis and repair, and cell cycle checkpoints, among others, that when injected into the ovary, reactivates or rescue these dormant follicles that remain in the ovary by upregulating different proteins in human ovarian tissue related to the regulation of follicular activation, also markers of oocyte quality, protection against apoptosis, and even with the folding of receptors for FSH and LH. Based on that, we have started in EB the first prospective observational multicentric and randomized pilot control trial seeking to evaluate this plasma treatment in 42 POI women diagnosed according to S.I.F.E.S with a proper control group. And hopefully next year we will present the results of this study. Because this is where we are now on the pathway of ovarian reactivation, using different stimulation protocols, adjuvant therapies, PGTA, and finally egg donation for women with no other options. In the last years, we have realized that the in vitro activation, the ovarian fragmentation, and the ASCOT technique seems to work for different types of patients. For example, the fragmentation for these young, intermittent POI women, the ASCOT technique for poor responders, and hopefully also for POI. We have started to work also with these plasma treatments, but we need to keep in mind that we need also to work on cell repair. Because, for example, telomere length, DNA damage, which is one of the main threats for human oocytes, and oxidative damage need also to be repaired, as they are increased with aging. Because the demand of these reactivation techniques is increasing both in the disease and in healthy ovaries due to postponed maternity to advanced maternal age when both the quantity and the quality of the oocytes are decreased. Well, I would to say thank you for your attention, and I would to thank all my colleagues from EB-RMA, EB Foundation, and Hospital S.I.F.E.S, especially to my mentor, Professor Pellicer. Grazie mille for your attention. I would be happy if there's any question about the talk. Thank you. I know it's tough and it's very early in the morning. No worries. She's coming.
Thank you. That's, of course, chapeau. Okay. One thing is, of course, you said that it's unethical to have a control. One crucial thing in these studies is that you need a control group. And I think it's unethical not to have, because we're working with somehow invasive procedures, and so that would be crucial, I think. Second, just by the gut, if you would be forced to invest in one of these techniques, what would you choose?
Well, I would not invest only in one, because I would explain that. Because what we have learned is that they work through different mechanisms. And the diminished ovarian reserve is completely different to a POI woman and completely different to an aged woman. So each technique is modifying different pathways and repairing different things, although what we observe is an increase in antral follicles. But the mechanism of damage and repairing is completely different. So I think that we need more both clinical trials, but also basic research to understand how each one. So we could, in the future, hopefully offer the best technique according to the diagnosis of our patients. And maybe we need to combine some of them or still work on.
Yeah, I understand.
Yeah, but I wouldn't say, as I mentioned at the very beginning, I feel, that's my feeling. But I feel that there's not, hopefully I'm wrong, but I feel that there's not going to be one unique technique that works for everyone. That's why I cannot choose right now.
Basta. Okay. Thank you.
Thank you so much for this very stimulating presentation. I just have a curiosity. You have talked about PRP. Do you think that PRP can be easily used in one or more of phenotype you have illustrated and in clinical, I'm talking about clinical setting. Do you think that we should use in an easy fashion?
I think that with PRP, what happened is that we have used it in other fields of medicine for many, many years. So we felt more comfortable with PRP, although we don't have to, because we need to check how PRP is working. The thing with PRP is that with the other techniques, we have started using animal models or lab studies before to move to patients. But with PRP, we made exactly the opposite. As we feel comfortable with PRP, we start using it in patients. But there's a gap in all these mechanistic and basic studies. So we do not properly understand how PRP works on the ovary. And that's why I say that we need more research to understand how PRP works. Because some authors say that seems that PRP is doing something on embryo quality, but we don't have data, it's just a feeling. So we cannot only rely on feelings when doing treatments for patients. Okay. Well, thank you.